are you? This is Dr. Amanda from StraightSmile Solutions, and today we're going to be talking about fixing overjets, or as some people call them, overbites. Really, an overjet is where your front teeth are ahead of your lower teeth, or your lower jaw might be a little bit small, different ways of describing it. So let's talk about the best way to fix this. And the reason why I'm launching this series is because I get a lot of questions from just consumers, parents who just don't understand. Like, they're getting different recommendations from friends, from other doctors, from orthodontists, from their general dentists, and they don't understand what's best. And yeah, it's really confusing. So let's just get kind of the straight story on what the different options are, what your doctor might be telling you. And I can't say what the best way to fix a child's bite is without, examining them in my office. But in any case, I just want to explain the different options to you so that you have the power to ask the right questions. Okay, so here in this infographic, you're going to basically, it's just saying, is it better to do appliances or is it better to use rubber bands? Of course, another option might be jaw surgery, but that's way down the road. Nobody wants that. So basically, there's going to be two main camps in order to fix this. So camp number one is who I describe as the doctors or the parents that believe in early skeletal correction. Now, I know that sounds weird because I'm saying skeletal. That's not a skeleton. It just means finding the source of the problem. And if the source of the problem is having a jaw discrepancy, like the lower jaw just genetically didn't grow appropriately to the right size, this could be genetic. It could be environmental. It could be the way a child slept or habits that they have, resting their hand on their chin in class, lots of different things. Thumb sucking, lots of things can hold that jaw back, okay? So what we're saying here is maybe one option is to go ahead and stimulate the growth of the lower jaw to correct the bite discrepancy while you still can, while the bones still have that genetic predisposition to, it's a big word, to grow correctly. So that's early skeletal correction. And that's one camp. A lot of orthodontists are totally in this camp. A lot of pediatric dentists are totally in this camp. A lot of pediatricians are totally in this camp. It's natural. It's healthy. It's the way it's meant to be. Of course, I'm a big fan of this. You can hear me talking about it. This usually must, though, this is the key, must be done between the ages of around 6, 7, 8, and 9. Could be 5, 6, 7, 8, 9, 10. But you really have to dial in to the skeletal maturity of the child. You can check with the pediatrician. There's a lot of indicators for skeletal growth. This could be a whole nother series, how to find this out. You can read x-rays, you can read hand-wrist diagrams, you can read the cervical age, the age of the bones in the upper part of the backbone, so many different things that you can do, okay? Option number 2 is to wait until the child's in regular braces, comprehensive braces, or aligners, and to fix it with rubber bands. Could be rubber bands, could also be something like a Jasper jumper, a Herbst, all kinds of little pistony devices, Amara, all different synonyms for this, okay? But basically what we call this is dental alveolar correction. And basically that's a fancy word of saying we're tipping the teeth to make the teeth match up. We're not fixing the jaw, we're tipping the teeth, okay? So we're leaning the lower teeth forward or pushing the upper teeth back to get them to match up better. Overall outcome, I'm not going to say it's the same because it's not the same, but the overall outcome is yes, the bite will appear corrected, it'll function correctly, but how it got there is different, and the way it may look on your face when you turn a profile view may look different. Maybe you like that look, maybe you don't like that look, but I think you have to understand the difference, because if you wait too long and decide to go with the late dental alveolar correction, too late, where maybe the girl has already finished her skeletal growth, this could be as early as age 8 or 9 in a girl, where you're already outside that window where it's possible to get skeletal correction. And your only choice now is either dental alveolar correction or a jaw surgery. So it is not much you can do in that case. So that's why I think it's important that all parents, when we start to see a discrepancy in the bite, are given options. And I really, really encourage every single general dentist and every single pediatric dentist and every single pediatrician to educate themselves on what the different options are so that they can give each parent a choice on how they want to treat their child and what the risk, benefits, and alternatives are. That's pretty much all I wanted to say here. We can dig more into this later if you want to talk about rubber bands, you want to talk about the different appliances to correct bites. There's so many different appliances. All of them work slightly differently, but all of them are just about the same, ultimately. So fixing bones or tipping teeth. Hey, it's Dr. Amanda with StraightSmile Solutions, and today we're going to be talking about the My Phase 1 Smile Index. It is like a little screening questionnaire that we created about a year ago. It's something that we give out to our clients with StraightSmile Solutions. Anytime they ask, we support them to use this. If you are not a client, we will be selling it, kind of like an ebook, for a small fee. How you choose to use it is how you choose to use it. Basically, it has about 2 pages of screening questions, and it'll automatically calculate the points. At a certain level of points, it's strongly recommended that you start with phase 1 treatment on the patient once the patient is 7 or 8. The lower the points, the less crucial it is. It's not always cut or dry with phase 1. It's just a recommendation. As you've seen my other videos, you know that the goal of phase 1 is to set the patient up for success so that, there's always a chance with phase 1 that you might not have to do phase 2 or that it won't be medically necessary, at least. If you get the bite just right, the arches expanded the way they're supposed to be, grow the jaw to the way it's supposed to be, then often you don't need to do phase 1, or at least there might be some very minor, rotation, something very cosmetic that could be optional at a later date. So the goal, of course, with phase 1 is to get the arch width ideal so that the teeth have space to be successful and grow in. If you build it, they will come. To, of course, grow a maxilla if it's underdeveloped, grow a mandible if it's underdeveloped, improve the airway. Of course, cosmetics is an issue as well. Function, the ability to properly eat, bite, and stuff like that. Eliminate habits, everything like that. So we've always given out this index to any of our clients as just a part of what we do. If you're not a StraightSmile Solutions client and you'd like to try this index, we will now be basically selling it like an ebook. So you can just purchase it. No instructions, basically use it as you see fit. If you'd like to have some tutorial or some instructions behind it, we are glad to teach you as well. And we'd be glad to talk to you a little bit more about that. So let's talk a little bit more about phase 1. We've already talked about it a little bit. Here's some of the price points that I recommend for that, for your practice. If you're going to do phase 1, most likely you're going to need a second phase 2 later. Whether you choose to keep the phase 2 in your house or not, in your office or not, you can always decide that later. I love the idea of pediatric dentists doing phase 1 because it's a small commitment that you can handle. And then later, if everything comes in like you planned really well, you can always do the phase 2 later. Remember, insurance is probably only going to pay once. So if you wipe out the insurance in phase 1, there's no bigger way to piss off a parent than all of a sudden telling them, by the way, you owe me $5,000 for phase 2. By the way, insurance is going to cover that. They will be furious. So you need to be really, really clear with the patient, with the parent. If you're going to use the insurance now in phase 1, it might cover the whole thing or most of it. But later if they need phase 2, which is likely that they'll need something, need in quotes. It may be a little bit more cosmetic, less functional. It may not be something they have to do immediately, but most likely they're going to need a little bit. And it could just be a few express aligners, but we can't predict the future. All we can do is set things up for success. So in comparison, comprehensive is one go, do it all in one go. But remember, right now with phase 1, you're trying to harness the growth during the prepubertal, pubertal phase. And this can happen in a girl at 8, 9, 10, and often does happen by 9, 10. And they may only have 8 permanent teeth in at that point. So you really now, more than ever, need to be doing phase 1 so that you can harness the growth. If you wait for comprehensive until they're done growing, you're not going to get a good outcome. So it's really important to understand that and understand growth a little bit more. Here's some of the options that you can do in terms of appliances for phase 1 in your office. You don't have to do them all, but these are just suggestions. Expanders come in all different forms.
myofunctional trainers, distalizers, ways to upright teeth, habit appliances. I'm not a huge fan of headgear, not this kind of headgear, but I like the protraction face mask that moves the upper jaw forward. That's great for class 3. That works really well. And growth modification devices. I mentioned the My Phase 1 Smile Index. That is something, again, if you contact me before Sunday evening, tomorrow, I'll be glad to email that to you. You'll need to email us directly, and you can go to our website to do that, and I will send you a copy of that. Normally, there's a fee for that. It's a free screening form that is used by our clients, but I'll be glad to give it to you. And actually, I thought it was going to be on my page to upload, but it didn't show up. So same thing with our hand wrist x-ray analysis form. We created this. We found an easy way that we just created on our own. This is copyright to be able to screen your patients to know their growth. Super awesome. A lot of pediatricians love our form, and it's something that you could actually bring this if you wanted to your pediatrician. What a great way to network and to get more clients. We've talked a lot about phase 1, expanders, different types of expanders, RPEs. Great way to develop the arches, to fix certain types of bites, deep bites, open bites. And you can even build all kind of bling in them to help with overjets.
Class 2 correction, okay? Overjet correction. We're going to be talking about twin block therapy. And twin block is a key appliance I like to use in growing kids. Now, if you want success with this appliance, and this is the lower and this is the upper, okay, you need to pick your patient wisely. By picking your patient, first of all, you need to pick a patient who has overjet, of course. I'll show you like a good patient. Okay, so this is what this patient looks like. Okay, this is a great patient for twin block therapy. You know, half to a full cust class 2, growing patient, has overjet, in mixed dentition, not permanent dentition. What else? In terms of skeletal maturity, you need to do a skeletal maturity assessment, okay? So that means you need to measure and make sure your patient is still growing. How do you do that? You can't just guess. You can't just say, are you still growing? Because this thing is not going to work, and this is going to be a complete waste of time if you do not choose wisely. So the best way that I like to do this, and you can ask a lot of questions, but is to go ahead and do a hand wrist analysis. And I've done a separate video on this. If you have a ceph plate, it's very easy to do. If you do not have a ceph plate and you can't do this, then you're going to need to ask a lot of questions about skeletal maturity, where they are in the puberty process. They need to be barely started, you know, on the early end, not already completed. They shouldn't have had their menses. They shouldn't have their voice changed. They shouldn't have anything like that. Not even close, okay? If you want this to work well. So also let's talk about psychosocially, what is the ideal patient for this? So I don't like to do these kind of appliances that can be a little bit bulky in a patient who is in junior high. They need to be still in elementary school. So you need to ask the questions. Don't assume because they're in 6th grade that they're in elementary school. They may be in middle school. So this is best in a 3rd, 4th, or 5th grader, okay? Even 2nd grader, any of the above. You can do this very young. It is not at all going to work in junior high because you can see how bulky, I mean, even though from the front, you can barely see it. You know, this is what it looks like from the front. So that part is nice, and it is in 2 pieces, unlike your Bionators and your Frankel 2s and other things that are in 1 piece and really affect speech. But it's still a little bit bulky. There's some acrylic blocks on it, and vertically, you know, they're going to be talking and their speech is going to be a little bit different. People will notice, people will be asking what's in your mouth. They can practice, they can probably get 90% improvement with speech, but people will still know. And it kind of gives you a little bit of a long face appearance. So even though this isn't permanent in junior high, it's just not going to get worn. It's not. I don't care how great the kid is. It's just social suicide. So pick your patient wisely, right? So we said mixed dentition, just starting puberty or early in the puberty process, 3rd, 4th, or 5th grade. Skeletally hasn't gone even close through puberty left yet. And we're going to leave this in actually about a year, 9 months to a year. It's going to be in a pretty darn long time. So you need to make sure it fits well. As new teeth come in and out, you have to be ready to adjust it as needed. Okay. So that's pretty much how it works. You're going to go ahead take your impressions or your scans. You're going to ask for a twin block. These little acrylic blocks, okay, are going to keep the mandible positioned forward. So you can see how they're going to have a little bit of an open, open mouth like this. It's going to give them a little bit of a different look. They're going to talk a little funny. But this constant forward position of the mandible does encourage a deficient mandible to grow over time. It's not just smoke and mirrors. It actually will grow if the patient does wear it. That means 24/7 for about 9 months to a year, okay? If they don't wear it 24/7, 9 months to a year, it's not going to work at all, okay? So then it's a waste of everyone's time. So of course, like with anything, I tell you, make sure you have your compliance paperwork in check. Make sure you've created a compliance program. If you don't know what this is, feel free to connect with me. This is something that we do routinely with our concierge patients. Concierge clients. We help you set all this up so that you can do removable appliances and not get dinged if the patient isn't compliant. Like you have all your systems in place. Of course, you're not just going to let the patient go either. You're going to be having them check in. You're going to be measuring the overjet and making sure it's working. Within 3 months, if you don't see a kind of a noticeable change, they're not wearing it. So you might as well discontinue it, So that's pretty much it. If the patient has a deep bite, you might need to do some modifications. That means you're probably going to want to draw off some of the acrylic behind the block right here, or some of the blocks behind the curved part, okay, so that the lower teeth can start to gently extrude. Same thing, you might want to take off a little bit under here, okay, and maybe even reduce it a little bit forward of the notch here. So slowly it can start to level out. But for the most part, this is a great appliance. If they do wear it for that 9 to 12 months, you can anticipate 3 to 4 millimeters of jaw growth, which is a pretty sweet class 2 correction. And the rest you can always get with elastics later in your braces or aligners. So this will reduce to eliminate, if you start early, the need for jaw surgery or tooth extractions. So that is the why behind the twin block. Hey, it's Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today I'm going to talk to you about Bionators. And Bionators are definitely one of my go-to appliances for kids in the mixed dentition, kids with large overjets. The cool thing about Bionators is that they can be customized, not only in terms of color, so the patient feels like that they can design them, but also for various bite issues, whether, you're trying to open a deep bite, try to close an open bite. For the most part, Bionators are used to advance a mandible. So I'm a huge fan, if you've heard my other videos, about forward orthodontics, not moving things backwards, like say a Carrier or a Headgear or a distalizing appliance that's backwards. So to fix an overjet, if you're doing backwards orthodontics, you're taking the top jaw or the top teeth and moving them back. We don't want to do that. So especially if we look at a patient and we're looking at their profile and we're like, dude, this person has a really tiny mandible. We're looking at the ceph, maybe we're looking at the airway thinking we need to do whatever we can do to open the airway, advance the mandible, not close the airway by retracting the top teeth or the top jaw. So that's why I love Bionators. They're also very simple. Like I said, very easy to customize both in color and in design to get what you want with the bite. Of course, they're 100% compliance based, right? But timing and picking the right patient with the Bionator is really critical. They just do magical stuff as long as they're worn. And they really do need to be worn 22 hours a day, usually for, I'd say, 9 to 12 months. So picking the right patient is key, explaining the why behind it. If they're only wearing it at night, it's not going to work. So they have to actually wear it to school. It is a one-piece appliance. So like I said, these things have been around for 100 years. They're definitely much more sophisticated, but there's different versions of them. They call them activators. There's all kind of trade names, but for the most part, they all lump into a classification of a mandibular advancement appliance, and I call them Bionators. Bionators are the most generic version. You can order them from any ortho lab. You don't have to take a special class or anything like that. Lab fee is probably in the neighborhood of 200-ish, depending on how much you bling it out. Like I said, it's a one-piece appliance, so you can figure if the patient's wearing it, doesn't hurt or anything like that, but it's going to be a little tricky to learn to talk with it in because it does need to click in. It's
being made with the lower jaw set forward, almost like the way, if you know Invisalign, their mandibular advancement version, it's similar to that. Now, this is going to work way better, especially in mixed dentition, than their MA. But you want to do this when the patient is ideally still growing, actively still growing, or prepubertal even, 8, 7, 8, 9, 10. You're probably not going to have a lot of success. And I encourage you to ask a lot of questions as to where the kid goes to school, what grade they're in, what does a school district look like in your area. Once that patient's getting into junior high or middle school where they're around older kids, forget it. It's not going to get worn. I can tell you it's not going to get worn, because obviously it's going to work great in second, third, fourth, fifth grade, sixth grade, depending on what school they go to. But beyond that, don't bother. You'll need to move on to something else. But yeah, it can be definitely a phase 1 appliance, or it can be part of your comprehensive treatment. You do this first, and then once you've had some jaw growth, then you can go ahead and put the braces or the aligners on. Or you can even move into Invisalign MA, and finish the treatment up with that.
Hey, this is Dr. Amanda here from StraightSmile Solutions, and I had some questions about sagittal expanders, or you can call them sagittal distalizers. So sagittals basically are very similar to an expander. They work exactly the same way in functionality and in mechanism, but basically it's a jack screw that's built into a removable appliance, not unlike a retainer, that can help to distalize a posterior segment of an arch. So for example, here you see maybe there was an early loss of a tooth and the space collapsed. Maybe there's a blocked out premolar. So you can see the jack screw that's right here. And the idea is that we're going to go ahead and deliver this appliance before we do braces or aligners, or maybe just only for this reason, maybe as a phase 1 kind of appliance or an interceptive appliance, to go ahead and distalize the posterior segment to open up space for the new tooth, or to open up space for an implant or a bridge. Okay, so it works fundamentally the same way. You can get, I would say from my experience, up to 2 millimeters of space back. That's a lot of space, right? The way I deliver it is I go ahead and deliver it. Usually I'm going to do about 1 turn a week on the appliance, and please follow my instructions from my expander videos, my RP videos on how to do a turn. I'm not going to go over that today. If you don't know where that video is, you can message me and I will send it to you. It's in my library. You can search under RPE and it should come up, okay? But you're going to go ahead and turn in the direction of the arrows. Do it at nighttime before bed. Have the patient wear it. They do need to wear it 24/7 in order for this to be effective. That's pretty much it. So you're probably going to end up doing, ultimately you're supposed to get 0.25 millimeters per turn. So you can do the math. You're always going to lose some space. So you're probably going to end up doing, you're going to have to turn probably 30, 40, 50% more than you think you need. 15, 16, 17 turns. It's going to take a few months to open this up. What you're going to see is this segment distalize first, okay? And then if there's other teeth, they're attached to the PDL, it'll start to come out with it. So anyways, that's pretty much how it works. I'm excited to show you sagittal. I do use them regularly and I recommend their use. And I think it's an easy way to get improvements without having to do fixed braces, or to make your fixed braces easier.
And the big question today that I get asked a lot is Headgear bad? Does Headgear work? Why are some orthodontists using Headgear and some orthodontists refuse to use Headgear? So let me tell you a little bit about Headgear and what it has been used for historically and how things are changing now. How orthodontists and dentists and even pediatricians are thinking way outside the box and realizing that there's better ways to meet these objectives. So historically, Headgear's been around for hundreds of years. Headgear is basically, in this case, I would call this quote unquote neck gear in this picture. I know that's not what we call it. In orthodontics, we call it cervical headgear. That means goes around your neck. There's also different forms of headgear. There's ones that go over the top of your head. And don't mind me, I used to love headgear. I used to do it all the time as an orthodontist. I loved it so much that when I was 8 years old, I made my own headgear out of paper clips and now and laters, and I wore it to school because I wanted headgear so badly. So the fact that I'm even talking about this to thousands of people all over the world is pretty cool. Because you know what? Let me tell you all about headgear. Let me tell you how I'm a reformed headgear orthodontist, and I would never, ever, in most situations, use it now, and why. So Headgear is used for overjet. Overjet is what patients often call overbite. It gets confusing. Two different terms. The way you all use them and the way orthodontists use them is different. So I'm going to speak your language today, and I'm going to say when the front teeth are more ahead of the lower teeth, okay? So when the top teeth are more ahead of the lower teeth, we want to try to get the jaws to match up a little bit more. Why does this happen? It could be all one of many different reasons. It could be genetics. Maybe Overjet's small lower jaws run in your family. Okay. Well, some people say you can't change nature, but you totally can if you start early. So the earlier you start with these things, the better. I'm talking like 4, 5, 6 getting started. I'm not talking 12, okay? So you do not need to wait for your family dentist to refer you to an orthodontist to get these problems addressed. If your family dentist is not referring you, you are welcome to make your own appointment with a friendly orthodontist near you. And if you don't get the answer you're looking for and it's not feeling good in the pit of your stomach, first of all, you're welcome to reach out to me at any time, StraightSmileSolutions.com. You can go to my webpage, you can go to the patient webpage and just get tons of information about different topics. You're also welcome to ask questions. I'm not a substitute and my team's not a substitute for medical advice, but we'll tell you not about your own particular situation, but we'll tell you about different options out there and how they're used. And we can also help to direct you to a very friendly orthodontist near you who specializes in growth and development and believes in airways and believes in correcting bites the right way. And we will find you that orthodontist if you need one. So don't worry about that. Give us that job. We don't earn any commission for this. This is just a gift that we give to the community to help you out because we believe in this. So let me digress. Let me go back to Headgear. Why is Headgear quote unquote bad? Because what it's doing is it's pulling those top teeth and restricting the growth of the top jaw, which is your maxilla. Well, your top jaw or your maxilla is extremely important. It's connected to your airway, your nose, and all of that. So if you're restricting the growth of that, a lot of not so good things can happen long term with the growth of your face, the shape of your face, the amount of air that can go in, the space for your tongue to go so that you can swallow correctly. This can affect all kinds of health issues later, okay? As well as the way you feel, the way you sleep. So we as orthodontists collectively, many of us are evolving and we're stepping away from using Headgear to fix an overjet and we're moving towards all sorts of other systems to correct it that don't involve restricting the growth, that actually encourage, go think the other way. If you have an overjet and your upper jaw is ahead of your lower jaw, let's encourage the lower jaw to grow instead, right? Everybody wants a nice full profile, full lips, right? Now there's a few situations and of course your orthodontist will measure to see what's right, where sometimes Headgear is necessary, but I would say it's very few and far between.
And today we're going to be talking about Class 2 and Class 3 elastics with aligners and what to do if you're not using Invisalign. Obviously, if you are using Invisalign, it's significantly easier. Here's an example of what their precision cuts look like. You can see here. Can you see it on the canine? I'm going to go ahead and hook that on for you. Now, in terms of what elastics to use, you're going to really have to try them in your patient and see. There's no wrong or right answer to this, and it really depends on the morphology of the teeth and the bite. So let me show you what this looks like. See, this would be for a Class 2 elastics. It just hooks right on there. And then down on the bottom, it's going to go ahead and hook to the lower molar. You can use either the first or the second molar. You could either use a button or you can use precision cut to precision cut. So many, many options. It really depends on your personal preference. So we're going to go ahead and show you a diagram shortly about that. If you're going to go from button to button, you can do that too, actually. You can probably use heavier elastics. You might be able to use 3/16 heavy or even possibly 1/8 heavy. If you're going from precision cut to precision cut, it's going to be a little bit different. In that case, let me do that for you. I'm going to set one up for you. You're going to have to use a lighter elastic. You know, in that case, it's going to be a little more challenging because you are going to have to make sure that they're not getting displaced. So let me show you kind of what that looks like. And this is, I'm using a combination of ClearCorrect and Invisalign. But so that's going from slot to slot. Okay. So that means the patient is going to go ahead and assemble this outside the mouth and then put it in their mouth all at one time, as opposed to going from button to button where you're going to put the aligners in first. The buttons will already be on the teeth and then hook the elastics on.
You know, what's a Class 2 elastic? You can see how the orientation goes. In general, it's an elastic that normally hooks from the upper canine to the lower molar to correct an overjet. The actual size of the elastics is going to really vary. I'm talking about the diameter is going to vary on the amount of overjet or the size of the teeth. So you really should stock several sizes. I would recommend stocking 1/8, 3/16, 1/4. Those are some good ones to stock. Then there's also strengths. Normal class 2 elastics, I'm going to use 6 ounce, but it also depends on what wire I'm on, and we can go into that more later. So do message me, visit StraightSmileSolutions.com if you would like some more suggestions. But this, normally I'll run my elastics on a heavier wire. I'm not going to run it on an eye-tie wire. It's going to be a stainless steel wire. I know that's really different than a lot of other IDB systems that are out there. And I'll run 3/16 heavy. But again, you got to stock lots of sizes. It's not a one size fits all approach for elastics. There's some thought that needs to go into it. Do not run it on a light wire. All sorts of crazy things are going to happen. And that's basically all about class 2 elastics. Take them on, take them off. Every time you eat, they absolutely have to be on 22 hours a day. No ifs, ands, or buts. If the patient only wearing them 12 hours, 16 hours a day, they're not going to work. There's just basically a seesaw effect, and there's going to be significantly more discomfort. So if you do not establish this with the patient and the parent, at the beginning, they're not going to see success. You should, I'm going to say confidently, you will see a change if you're seeing them on 6-week intervals and they're wearing elastics. It will be evident. Okay. It should be quite evident, as a matter of fact. So if you're not seeing the change, you need to be confident in saying you're not wearing them enough. They may be wearing them 16 hours a day, but you need to troubleshoot. That means they need to be changing the elastics at least 4 times a day. Every few hours, they should be changing it. Usually I say 4 times a day: breakfast, lunch, dinner, snack, bedtime. That's 5, something like that. It's okay to change it more. You should be dispensing at least 2 bags of elastics every time that they come to the 6-week interval check. So, and remember, as you're correcting the bite, the wires are going to get pokey. You got to trim it, right? And you still got to check the patient.
Hi, it's Dr. Amanda with StraightSmile Solutions. We're here today to talk a little bit about biotrainers, myofunctional appliances, and phase 1 appliances, and how to incorporate them into your practice, how to incorporate them into your phase 1 treatment, how to incorporate them into your phase 2 or comprehensive treatment. And I'm very, very honored that Great Lakes Dental Laboratory has picked me to do a series of videos, educational videos on their biotrainers to help train orthodontists, general dentists, and pediatric dentists for indications of use. And I'm going to be working my way through their series of appliances and telling you more. I have seen a lot of great outcomes with these appliances. This is, I believe, a European-based company, and it's being distributed by Great Lakes in the US. If you have any questions, feel free to contact me, and I'll be glad to talk to you more about phase 1. I have a great monograph or phase 1 quiz that I kind of created, which will help you screen patients and to see if they need phase 1. So I'm glad to send it to you. It's called My Phase 1 Smile. Feel free to email me at info@straightsmilesolutions.com or visit my website at straightsmilesolutions.com, and I'll be glad to just give you a copy. I'll just give it to you. It's free. So I'm just glad to be helping people, and that's my ultimate goal. So today we're going to be talking a little bit more about one of the series of appliances, one of the first appliances in their series. It's called U Start. Letter U, Start. Indications for use are age 4 to 6. Okay. So we're thinking either primary dentition, full primary dentition, or very, very early mixed dentition. I would probably discontinue this appliance once the 6-year-old molars came in. So we're thinking like age 4 to 6, maybe 4 to 5. Once the 6-year-old molars come in or the first few front teeth start to come in, it's time to move on to the next in the series of appliances. I'm going to be giving you all kinds of gems and tidbits about phase 1 treatment and how to use these appliances, how to bill for insurance. There's just so much information I can tell you, and it's something that we work with our clients with all the time. So thank you so much to Great Lakes for giving me samples of all the appliances. I'm just going to kind of verbally tell you what I see and feel. You can see them. So this is the U Concept appliance, the U Start. Again, it's for age 4 to 6. Okay. This is just me saying, I would probably discontinue and move on to the next series once the 6-year-old molars come in. These are not custom. Okay. So that means that you can just order them. You can stock them. Prices are very reasonable. You may or may not get a discount or volume discount if you choose to stock them. Is this all you need for phase one? No, not necessarily. So phase one is interceptive treatment. You're getting the kid from A to Z. For me, you don't discontinue phase one until 6-year-old molars are fully in and front teeth, top and bottom, are aligned, and as well, and the arches are formed. So, it might be a part of the phase one process. Maybe this is all they need, but it's probably pretty unlikely. So some of the features that I recognize in here is basically you've got it's real soft, if you can see how I can just touch it. So I think it's going to be very comfortable. It does come in 3 colors, clear, which is nice because you can see the teeth easily through it, as well as pink and blue. So you can choose what colors you want. It has some eruptive guidance features on the inside, like little imprints so as the teeth start to come up, they're going to bounce off the wall and come a little bit straighter. They also have a firm version, which is a little bit more rigid, that only comes in clear. From my experience, those are good if you have a bruxer. Maybe you want to start with the soft. It's going to be much easier for the child to get used to wearing it if you start with the soft. And if you start getting bite throughs, then that's something you can move on to. What else? So I see other features in here that are good. Basically, it's going to work for any patient that has up to a 6 millimeter overjet, as well as a slight class 3 patient. You have to move on to a class 3 appliance if you do have a class 3 patient, but this is a good way to start. If they're in early mixed dentition or in primary dentition, you start to see some anterior crossbite, you're probably going to get a little bit of arch expansion, but I don't think you're going to get too much with this. I mean, it is pretty soft. Maybe if you need more arch expansion, you'll want to move on to the more rigid one, or you'll want to go into a Schwartz, or some type of expander, and feel free to connect with me on that. I have tons of YouTube videos on that. Looks like we also have, a little place, I call it a pillow, for the tongue to rest so that the tongue doesn't go down. It remembers to swallow up at the roof of the mouth. So just some tips on delivering this appliance. Initially, a good way, you don't just give it to the patient and say go, okay? So it's going to take some time, especially if the patient is a mouth breather. It's going to take them time to get used to wearing this. And we want to take baby steps. So I usually tell patients, hey, first night, why don't you try to wear it during one cartoon or, one video game or something like that, or while we read a book to bed. And then the next week you can move up to a movie, or while you do your homework. And eventually we're going to try to wear it all night long. Now, some patients might take a few weeks to keep it in all night long. Some patients might take a few months to keep it in all night long. Over time, the mouth is going to grow the musculature to be able to retain the appliance. And the nasal breathing is going to help the patient significantly. So, remember, if the patient has a cold or something, this is not a good time to start this appliance. We want to have patent nasal breathing. So if you need to address that with some allergy spray or something like that first with the child's pediatrician, you definitely want to do it. Also, let's just get into this. You need to be screening your patients well. You can't just give this to a patient because a patient that maybe has swollen tonsils or nasal or oropharyngeal airway blockage, this is not a good indication for the patient. Although this might help the patient, you want to make sure you're working with the child's pediatrician if you are screening Malampati, tonsils, stuff like that, and refer out as needed and collaborate with the pediatrician or the ENT. And I'm glad to give you some guidance around that as well. So again, this is the U-Start appliance for age 4 through 6, primary dentition or early mixed dentition. It does come in 3 colors, pink, blue, and clear in the soft. And if you move up to the rigid, it only comes in clear. You can order these from Great Lakes. Glad to tell you more. You can go ahead and visit my website at StraightSmileSolutions.com. Keep those questions coming, and I would love to see your cases if you start using them.
The number one exciting thing today is that the MA device, the MA feature component of Invisalign, has been FDA approved in the US. This is actually very exciting. You've probably seen some of my videos before. I'm not a huge fan of the design. I think there's a better way to do mandibular advancement. You can watch those. You can watch my criticism on it. But I'm excited that it did get FDA approved. I'm excited that doctors here will have an opportunity to use it. I've had some experience with it, not directly, but indirectly with clients, StraightSmile Solutions clients who have opted to put this into their treatment plans. These are doctors in Canada, Asia that I've worked with that have been using this for some time. It gets kind of mixed reviews from my clients, and we can go over that directly if you have questions. But, it's available. It's there. I believe, and this is my understanding here in the US, and of course, Align Technology never returns any of my questions or inquiries, so I'm just going off what I heard. hearsay, and if they are more than welcome to reach out to me and answer my questions. I believe it's only available in the phase 1 feature, the phase 1 treatment that you can get. I believe it's not a feature in comprehensive treatment at this moment or in phase 2. So that's pretty much all I know. Any questions, please visit StraightSmileSolutions.com. But again, anything that involves growing mandibles when it needs to be grown, of course, you have to know a lot about skeletal growth. You need to know a lot about so much you need to know. And I get very nervous that this power is now available. And I say power because used incorrectly, you can damage a child. That this power is now available for every single dentist out there in the US who's just certified in Invisalign. I don't think you have to take an additional course for it. I think it's just a button you push, and it makes me very uncomfortable, but I'm just saying that. So